Hello everyone, my name is Bruno Lima and I'm Assistant Professor of Medicine and Radiology at Vanderbilt University Medical Center in Nashville. And today we will discuss how coronary CT angiography is evolving beyond diagnosis and becoming a procedural planning tool for PCI. I have no relevant conflicts of interest related to this presentation. And I'd also like to acknowledge Dr. Carlos Golay, who's a leading researcher on this area for generously allowing us to use several of his animations that we include in this talk. So by the end of this session, I'd like you to be comfortable with three main concepts. First, what CT-guided PCI actually means and why this approach is becoming increasingly important. Second, how we can systematically use coronary CT for procedural planning, including virtual stenting, plaque characterization, calcium assessment, lesion preparation. And finally, we will review some of the current evidence and discuss where this field is heading moving forward. This is a really important document that reflects how quickly this field is evolving. The 2025 SKY and SCCT expert consensus highlights the growing role of coronary CTA, not only for diagnosis, but also for procedural planning and guidance. So what's happening now is that CT is moving upstream in the PCI workflow, and instead of simply identifying stenosis, we're using CT to understand vessel geometry, plaque morphology, lesion length, calcium distribution, and even physiology before the procedure begins. And one of the strengths of coronary CTA is that a single data set gives us a tremendous amount of information. So we can assess anatomy, we can assess plaque burden, vessel tortuosity, calcium distribution, physiology, myocardial mass at risk, and even simulate a virtual PCI. And what's important is that each reconstruction technique gives us a different procedural information. For instance, a MIP help us understand overall case complexity, axials help us with osteoanatomy and guide selection, NPR and cross-sectional analysis help characterize plaque and define landing zones. So the data set becomes a complete roadmap before the intervention. This is the workflow that we use here at Vanderbilt, which is based on the P4 trial. And whenever we are reviewing a CT for PCI planning, we always recommend approaching these data sets systematically because every reconstruction provides different information. So we start broad with 3D MIP to understand global anatomy and complexity, as we mentioned. Then we move to axials for coronary ostia and guide catheter planning. Curve NPRs is used for lesion assessment. And finally, cross-sectional images, they will help characterize the calcium burden and plaque morphology. And the key is that each step builds on the previous one. And the first step is really about understanding the overall procedural landscape. So using 3D MIP, we can quickly identify the number of disease vessels, vessel tortuosity, bifurcation, anatomy, chronic total occlusions, the overall calcium burden. From an interventional cardiology standpoint, this helps anticipate procedural complexity before they ever engage, the coronaries. For us, in the radiology or cardiac imaging side, this is usually a neglected reconstruction, but this is something that can actually be very useful in any scanner. At least, most of the scanners that people use, they are capable of generating 3D MIPS with just a couple of clicks. There's nothing fancy about that. But again, that's a very useful reconstruction for having this kind of overall idea of the anatomy. In those two examples, they show how useful MIP can be for understanding vessel geometry and complexity. If you show the case on the left for an interventional cardiologist, you can clearly see a very severe RCA obstruction here that can be easily stented over here. On the other side, you have severe calcifications. These cases are probably cases that gonna involve calcium modifying techniques like lithotripsy or shockwave. So it gives you a sense of what you need to do coming into the procedure, and that's why this is so useful for interventionalists. So another advantage is the ability to rotate the data set freely. And here you can see different vessels with different levels of complexity. From the upper left side over here, we don't see any significant stenosis. Here you can see, clearly the RCA obstruction. And then as you can get, to the right side, you're going to have more and more complex cases, with a lot of calcifications, CTOs. And this is something that, again, you can just lay your eyes and you can immediately have a sense of the complexity. That's why 3D MIPS are the first step for PCI planning. So after assessing overall complexity, we move to the axial images. And this step is particularly important for procedural preparation, guide catheter selection. So axial images are extremely useful for evaluating coronary osseolocation and takeoff angles. So this becomes important because challenging coronary origins often translate into more difficult catheter engagement and reduced backup support during PCI. So knowing this anatomy beforehand also allows interventionalists to select the appropriate guiding catheter before the case starts. So one practical way to think about coronary origins is using a clock face model of the aortic root. So typically the RCA originates around 11 o'clock position and the left main is around 4 o'clock position. So CT allows us to define these orientations precisely and anticipate engagement challenges before angiography. And the right coronary artery is particularly variable. Here you can see examples of a normal takeoff at 11 o'clock, an anterior takeoff at 12 o'clock, and a left cusp origin. So these variations can dramatically affect guide support and catheter choice during PCI. So this is an example of a standard RCA origin. On the CT image, the vessel arises from the expected location. And on the invasive angiogram, you can see straightforward engagement with good guide support. In contrast, this patient has a much more anterior takeoff, and without prior CT information, engagement can become more challenging and may require multiple catheter exchanges, which exposes the patient to more radiation and also more contrast. So a pre-procedure CTA would help anticipate these situations and streamline the procedure by selecting an unplatzer catheter, which would be more coaxial with the takeoff here. And here we have a more extreme example where the RCA originates from the left coronary cusp. So these anomalous origins can significantly affect procedural strategy and catheter selection. So knowing that beforehand, again, provides an excellent roadmap before intervention. So once we understand access and coronary anatomy, we move into detailed lesion assessment using multiplanar reformations. So curve MPR is probably one of the most important tools for PCI planning. So by following the vessel center line and unfolding the artery into a single plane, we can accurately assess stenosis severity, lesion length, plaque distribution, plaque composition. This is also extremely helpful for identifying landing zones and estimating stent length. So these examples show curve MPR reconstructions of the LAD, circumflex, and RCA. And what's helpful here is that the entire vessel can be evaluated continuously without overlap or foreshortening, which is difficult with conventional angiography. So let's apply this workflow to a real case. And this is a 61-year-old man. He has a CCS class 2 angina and no major traditional risk factors. So using CCTA, we can evaluate each coronary territory systematically and identify the lesions responsible for the symptoms. And if you look closely at the LAD, at the distal left main, you have severe stenosis here. And this is where CT-guided PCI becomes particularly powerful from an interventional standpoint. So since we predicted that the patient had a left main disease, um, you're gonna prepare the cath lab ahead of time, including the guide selection, perhaps plaque modification strategies, intravascular imaging planning, anticipated stent sizing, or even when to schedule the cath. For instance, in a more complex case like this, you're probably going to leave it to be like your last case, so you don't have to be like rushing, through your schedule. And another major advantage of coronary CTA is during, plaque characterization. With CT, we can differentiate between lipid-rich plaque, fibrotic plaque, and calcified plaque based on attenuation characteristics. So this is very relevant also procedurally because plaque composition strongly influences the lesion preparation and stent expansion. And beyond stenosis severity, CTA also identifies high-risk plaque features associated with vulnerability. And these include positive remodeling, low attenuation plaque, spotty calcifications, and the napkin ring sign. So these features, they may identify lesions with higher risk of future events or procedural complications. And when we evaluate calcium, it's not just the amount of calcium that matters, it's also the distribution of calcium. So a lesion with a focal eccentric calcium behaves very differently from a lesion with circumferential calcium. So once you start seeing calcium arcs approaching 270 or 360 degrees, the likelihood of stent under expansion increases substantially. And that's when you're probably going to need to use some of the calcium modifying techniques we discussed earlier. And also that's where CT becomes also useful, because it helps anticipate the need for atherectomy, lithotripsy before the procedure. Another major advance is in the integration of physiology with anatomy. So using computational modeling, we can derive vessel-specific physiology directly from the CTA dataset, and this allows us to understand not only where disease is located, but also whether it is functionally significant. As you can see in this case, you have proximal LAD disease, and there is a significant translesional pressure drop over here. So you have this abrupt change from blue to red. And as you can see on the right, it correlates really well with what we see on the angiogram. And this becomes clinically important because PCI outcomes differ substantially between focal and diffuse disease patterns. So patients with focal disease, as we can see here, they experience much greater symptomatic improvement after PCI compared to patients who have diffuse atherosclerosis. And we're going to understand, with this animation here. So as you can see, we pass a wire through the lesion, and we measure the fractional flow reserve, which is the FFR. And here, the FFR is 0.7, which is significant. But as we pull back and we cross the lesion, the FFR goes from 0.7 to 100. And there was this huge gap of 0.3 FFR units, or 30% translesional pressure drop, as we call it. So this is a marker that there is a lot of pressure, a lot of gradient here before and after the lesion. And then after we put a stent in, we inflate the balloon, look what happened with the curve. So all of this gap, all of this jump that we saw first, it pretty much flattens. We went from 0.7 to 0.95. So now there's just like a 5% pressure drop, which is non-significant. Now contrast this with this patient that has diffuse disease. So resistance accumulates gradually throughout the vessel rather than across a single focal lesion. So even if a severe stenosis is treated, there's going to be residual diffuse disease, which may continue to limit flow and symptoms. So in this case, the FFR is the same as 0.7, but as we pull back, we don't have that discrete lesion or that discrete jump. It's more of a gradual decrease in the translesional drop over there. So here, again, if we try to put a stent, let's say we are treating this more proximal lesion here. Now look what happened with the curves. We went from 0.70 to 0.80. Again, there is some improvement here, but the improvement was very modest. And these are the type of patients that would potentially continue to have symptoms, continue to have angina. And the pullback pressure gradient helps differentiate focal from diffuse disease physiology, as we mentioned. So a high PPG suggests focal disease that is likely to respond well to PCI, whereas low PPG values, they indicate diffuse disease with less expected symptomatic benefit after stenting. This is data from Carlos Collet and collaborators that was published at JACC Cardiovascular Interventions in 2022. And the same thing we can do on the cath lab, we can also do with FFRCT. If we place all of these markers across the vessel, we can do what I call a virtual pullback. And as you can see here, the virtual pullback is very similar to the actual FFR that was derived in the cath lab. So you can see that the same area of translesional pressure drop appear over here. So this case demonstrates a classic focal disease pattern that we saw before. So on the invasive pressure wire, the pullback, and on the FFRCT pullback, you can see an abrupt step down in pressure across a short lesion segment. And that type of physiology is important because, as we discussed previously, it will identify the discrete target responsible for ischemia. So again, these are the patients that will derive the greatest symptomatic benefit from PCI because there is a focal obstruction that can be effectively treated with stenting. Now compare that with this diffuse disease pattern. So instead of a sharp focal drop, there is a gradual continuous decline in the pressure along the vessel, and that tells us resistance is distributed throughout the artery rather than concentrated at a single lesion. So from a clinical standpoint, this is important because even technically successful PCI may not provide the same symptomatic improvement if the underlying physiology is diffuse. So these examples really highlight why understanding disease patterns matters. So on the left, the patient has diffuse disease, low PPG index, and in this setting, PCI may provide limited benefit because there's no dominant focal target driving ischemia. On the right, the patient has a focal physiology pattern with a high PPG index, and here intervention is much more likely to improve symptoms and restore flow. So increasingly, the question is not simply whether disease is present, but whether the physiology supports revascularization. And to conclude, coronary CT is rapidly evolving from a purely diagnostic test into a comprehensive procedural planning platform. So modern CT allows us to integrate anatomy, plaque characterization, calcium assessment, vessel geometry, and physiology into a single non-invasive data set. And again, thank you so much for your attention. And it was a pleasure giving you and participating on this course.